Good afternoon, good morning, dear colleagues in the African region and around the world. I am very pleased to present today in the COLDA 2020, the virtual conference on liver disease in Africa. And I'm very pleased to present to you on the question of the inclusion of vulnerable groups in hepatitis C prevention, testing and treatment. On the picture, you can see this is a small photo of a visit that we did earlier this year, because before we were all locked down and not able to travel anymore, in Cape Town with colleagues from different countries in the African region to a drop-in center for most affected populations and injecting drug users and people who use drugs in Cape Town in South Africa. I have no conflict of interest to declare. Here's my short outline for today. I will start with some thoughts on the epidemiology of hepatitis C, and more specifically with regards to the African region and vulnerable groups, and then link that to the global health sector strategy and specific aspects of tackling the epidemic in most affected populations. And then conclude with some thoughts around the implications of this talk. So to start with, let me talk a little bit about hepatitis C epidemiology on the African continent and in vulnerable groups. First of all, you all will know that in 2015, WHO has estimated, together with the Center for Data Analysis, CDA, that 71 million chronic infections of hepatitis C are estimated globally, and the African region is home to around 12 million, similar to the Southeast Asian regions. Those estimates are currently updated. This is an interesting slide that takes the same data set and presents it in a different way. I've taken this slide from Ivan Hutin, who was working with the Global Hepatitis Program until earlier this year. And he has looked into the epidemic profiles of many of those 110, or of those 110 countries. On the x-axis, you can see to the very left, the countries with prevalence of under 1%, and then 1 to 2, 2 to 3, 3 to 4, 4 to 5, and above 5%. And what this slide shows is that actually globally most prevalent infections are in countries with a prevalence that is below 2%. There are certain countries such as Egypt and Pakistan and others that have a very high burden and high prevalence rates. But most of the countries have actually an epidemiology of a prevalence below 2%. And most of the African countries will be as well in this group. Why is this important? Is because the testing and treatment strategy in countries with lowish or medium high prevalence rates will be different and will be focused on more integrated approaches and more focused testing approaches, especially in the beginning, when compared to those countries with very high prevalence rates, where a more disease-specific approach can be justified and the most efficient. I wanted to share as well this data that shows the co-infection rates for hepatitis B and hepatitis C. So globally, it's estimated that 2.7 million people live with HIV and hepatitis B surface antigen, and that 2.3 million people live with HIV and hepatitis C antibodies. Africa is home to an estimated 19% of the global burden of hepatitis C co-infection, as estimated in this publication by Lucy Platt and al. In Lancet Infectious Disease in 2016. And the absolute number of those co-infected people in the African region is estimated at around 430,000 people. So there is an important part of the global co-infections are actually in the African region, and even more importantly, so for hepatitis B. If we look, for example, here at the example of Burkina Faso and the hepatitis C epidemic in this country in West Africa, and this is not untypical for many of the other African countries. Burkina Faso is a very high prevalent country for hepatitis B and hepatitis C. You can see on the left, on the upper graph, that in women, and then on the lower graph in men, the prevalence. So we can see that it tends to be higher in men in all age groups, that it is increasing over time in people of higher age. And on the right, we can see as well that there is a strong variation by geographical areas in this country. So we can see similar both cohort effects and geographical diversity in many other countries, including Cameroon and other high burden countries in the African region. I wanted to as well show the incidence estimates for the Afro region. Here, 310,000 new infections estimated by CDA in 2015 among the 1.7 million global new infections annually. Another data set from Bristol University estimates similar global data and quite similar data for the African region. So this gives a good orientation on how many new infections we are still seeing in the African region. This is new data that was first presented in AIDS 2020 virtual and by our collaborator Jeff Jin from the Kirby Institute in Australia. We commissioned a global systematic review of hepatitis C prevalence and incidence in men who have sex with men, high-risk men by WHO region. And what we have found is that it has, as it has been described already before, and as you can see here in yellow, that is, we included 146 studies and estimated that the global hepatitis C prevalence in MSM is 3.3%. This estimate was 5.8% for the African WHO region. And in red, you can see that this rate was higher globally and in the African region for MSM, who are as well HIV positive, and there's confirmed results from earlier studies that were not global, but coming from high-income countries, for example. So a population with quite a high prevalence rate, and especially among men who live with HIV as well. Here you can see the data for people who inject drugs for African countries where data exists and that we were able to include. You can see the sources on the right bottom. So this shows in orange hepatitis C viremic infection prevalence rates estimated in this population, and in blue in the general population for hepatitis C, and then in pink the prevalence of HIV infection among PWID, and in green in the general population. You can see here that with the exception of Kenya and Madagascar, maybe that hepatitis C prevalence is higher than HIV in most African countries among people who inject drugs. Unlike for HIV and hepatitis C, where in the general population, where really HIV rates are very often higher than hepatitis C rates in those countries. This shows as well even more so the important interlinkage between hepatitis C and injecting drug use. This is the estimated proportional attributable fraction of new hepatitis C infections due to injecting drug use, modeled by Bristol University for some African countries. Or said differently, this shows the proportion of new infections that are estimated to come from injecting drug use. So you can see here for some of those countries in the African region that, for example, in Mauritius, a big part of the epidemiology is driven, and the new infections are coming from injecting drug use for hepatitis C. And those countries like Tanzania, Kenya, and Mozambique, who have big drug user populations as well, and are big countries, 20 to 30% of the new infections are estimated to come from injecting drug use. So another hint of showing, or another data set of showing the important interlinkage between Hep C and injecting drug use. So what we have seen in terms of most affected populations and priority populations is really that those include those very stigmatized and vulnerable populations such as MSM and people who inject drugs, but they may include as well people in rural areas or very highly affected sub-regional areas, and people who live with HIV, for example. So how is that taken up and reflected in the global health sector strategy? You know that the global health sector strategy has given very ambitious targets for reducing incidence by 90% in orange on the left graph for hepatitis B and C, and 65% in black for mortality between 2015 and 2030. But I wanted to mention as well the key 2020 fast track targets for HIV that are the 90-90-90 targets, and that have the ambition to really reduce very strongly the incidence of HIV globally, and are instrumental to controlling HIV, because those two targets and strategies should not be seen as completely separate or in silos, and have very important overlaps. What are the core interventions that would make the biggest impact and allow to meet those targets? For hepatitis C prevention, that is blood and injection safety and harm reduction. And then there's the diagnosis and treatment core intervention for hepatitis B and hepatitis C that is instrumental as well for meeting hepatitis elimination. So where are we in terms of progress? Here, the bottom line for safe injection in healthcare facilities is that globally we're practically on track, and that the African region for this is performing very well and has very low rates of unsafe injections. In terms of harm reduction, the picture is different. Globally, we see a very important gap of this prevention interventions for people who inject drugs. And this is similar in the African region. In blue, you can see the targets or the coverage rates for needle and syringe distributed per PWID per year, which is the core intervention target of the global health sector strategy, and as well an important intervention for HIV, and in red the coverage rates for opiate substitution therapy. We've seen in this area emerging champions such as Kenya, and since a longer time Mauritius, with quite strong response and coverage rates, and emerging countries that implement more and more those interventions, such as Mozambique and Nigeria. But overall, coverage rates remain rather low or medium range. Another very important area with a gap is really the cascade of care for hepatitis C infections. You can see here in the left the global number of estimated infected individuals, 71 million, and you can see there's a big gap. Only very few people know their status, and even less are on treatment or cured. Here again, we have seen emerging champions such as Rwanda or Egypt or Mongolia and Georgia. But overall, on a global level and in the African region, the gap of diagnosis and treatment remains really very important, and there needs to be very clear improvements in this area. So a couple of thoughts how those key prevention and treatment gaps could be closed, especially with a focus to most affected populations, as this is the topic of my talk. First of all, I wanted to come back to this rather fundamental slide or graph on the right, which is what are the essential ingredients of a good national plan. And as we have seen, many more countries are now having national plans for hepatitis. But to really make a big step towards elimination, national plans need really some core ingredients. And this is, they need to identify the most impactful and essential services. They need to establish and describe a health information system that measures progress and allows for monitoring. And they need to address the question of the equity and the most affected populations and population coverage, as I have mentioned already, and ideally and needs to be costed and financed. If all that is met, then their national plans provide really the core backbone of progress towards elimination. And they really do need to include all those aspects. Secondly, especially for those countries with, let's say, a 1% or 2% epidemiology of the disease, so in terms of prevalence for hepatitis C, the UHC Universal Healthcare Coverage Framework provides really a very important framework. And so we can see here that this framework has 3 dimensions. One is the population dimension, who is covered, the service dimension in purple, which services are covered, and then in green, the financial dimension, which describes which proportion of the costs is covered by the system. And this framework really provides a basis to look into how can we best integrate and extend the services that are needed to those in need and extend the services that are available. So in terms of the yellow axis, it is really important to extend the services that are starting to emerge in terms of viral hepatitis response to those most affected and those most vulnerable. But as well to develop the services in an integrated manner and include them more and more in primary health care and, for example, HIV programs. As I have shown, there's quite a strong overlap in terms of epidemic and approaches. The third thing that I wanted to share, or the third aspect that I wanted to share, is quite a fundamental of our recommendations, which are the testing recommendations in view of treatment. And so why I'm showing this, because it comes back to one of the slides that I've shown in terms of lower or higher epidemic scenarios, and as well the data from Burkina Faso. So if we go on the right graph to the middle part, if there's really a country with a prevalence that's above 2%, this may justify a general population testing approach. But many of the countries that have prevalence below 2% or even below 1% will possibly need a mixed approach between very focused testing in most affected populations, and some of those are listed here from the guidelines on the left in white, mixed with focused testing in adults and adolescents and children with clinical suspicion, and where appropriate as well, consider burst cohort testing, meaning testing or rolling out testing to people of older age, because they might have been more affected. In conclusion, I hope I was able to show that many countries in the African region have epidemics with overall prevalence rates that are below 2% and sometimes below 1%. The data that we see is generally quite weak and needs improvement. I try to show as well that populations that have higher rates of hepatitis C infection include, in many countries in the region, people above 30 to 40 years of age, HIV infected people, and as well very stigmatized populations such as MSM and people who inject drugs. In terms of prevention gap, the most important gap lies with access to harm reduction and drug dependency treatment, and this would be an area of important improvement. to continue to reduce the rate of new infections, given as well that in the region the coverage of safe injection practices in healthcare facilities is very good. In terms of increasing access to testing and treatment and reducing really mortality over time, this will need to build on synergies with HIV programming and primary healthcare as well, because for many of the countries, a completely disease-specific approach will not be affordable and relevant. I thank you very much for joining today. You can contact the team on the address provided and the website on the link provided here on this slide. Have a great day.